Well, good afternoon and welcome to our webinar on tackling hip pain with Regenexx. My name is Russell Burgum. I'm a physician at Regenexx Des Moines. And I am a initially trained in sports medicine, and I've subsequent training in interventional orthobiologics, and I have additional board certification in musculoskeletal ultrasound. Well, we have two panelists who will be on as well, Natalie and Danielle, and they work with scheduling patients, working at helping get patients uh, uh, answering questions with patient education and with scheduling patients onto our schedule. So during the webinar, if you have any scheduling questions, you can chat with Natalie and Danielle, who will be with us for the whole presentation.
Yes, thank you, Dr. Burgum. Just so you guys know, yep, we will be in on the bottom of your Zoom. You should see like a Q&A or chat down below. So feel free to ask questions because he'll answer them at the end. But then also we're happy to look at like dates for you if you want to do an evaluation with Dr. Burgum. We will reach out to you as well as a follow-up to this webinar. Probably not today. I know it's getting late in the day, so probably tomorrow, but we will reach out to you as well to answer any questions and look at getting you scheduled if you're interested in that too as well. So you should hear something from Danielle or I, but feel free to chat to during the webinar. That's completely fine. We're here to help.
So Regenexx is a network of clinics. There's now over 150 clinics that have specific, where the physicians have specific Regenexx training on our techniques and our proprietary processing techniques for processing your own blood or bone marrow to create platelet-rich plasma or bone marrow aspirate concentrate, which includes stem cells. And that's where the quote, Regenexx, where orthopedic stem cells injections were invented, comes from, because Regenexx started at the Broomfield Clinic at the Centeno Schultz Clinic in Colorado. And in 2005, they were the first clinics in America to use uh, patient stem cells for orthopedic conditions. And so just our talk today will be focusing on osteoarthritis of the hip and other treatments of the hip, including treatment of gluteal tendon issues. Um, but the big focus will be on osteoarthritis, and I want to go over some new, exciting sort of breakthroughs on treatment of osteoarthritis of the hip. Uh, in the past, we would counsel patients that if you had severe hip arthritis, that our outcomes data show that you're not a good candidate for a Regenexx procedure because we would not expect you to have long-lasting outcomes. And that has changed, and we now have new protocols and new treatments with great data backing it up, showing that even patients with severe arthritis may be a candidate for a Regenexx treatment to help you avoid or significantly delay the need for a total hip replacement. So as a background, I mentioned I'm trained in interventional orthobiologics, and some people wonder what is that? It's a lot. It's a mouthful. Interventional means we're using um, high resolution guidance, either with X-ray guidance called fluoroscopy or with ultrasound guidance, to inject substances that promote healing of bone, tendon, cartilage, ligament. And those substances would be your own cells, not cells from someone else, not cells from uh, the placenta or cord blood, but we're using your own cells. And that's what orthobiologics refers to. We're using cells, biologics, to treat orthopedic conditions. And so a lot of people have been to a physician who's done an injection. And so how does that compare to interventional orthobiologics? So 95% of US physicians will do simple injections that are basically palpation guided. They'll find where they think the joint is and hopefully clean the skin and then inject into the joint without any type of guidance and without addressing other structures like the ligaments and tendons and support structures. Now, about 4% of US physicians will use some type of guidance, be it ultrasound guidance or fluoroscopy guidance to get injections into the joint. And about 1% would be considered interventional orthobiologics, and that's more advanced, a more advanced treatment where we don't just put a simple injection into the joint. If you look at the slide, there's of the different parts of the body. There's all these different things identified, like the patella tendon, the quadriceps tendon, the different ligaments, ACL, PCL. When I do a procedure, well, first, during your evaluation, I do a thorough evaluation to assess what parts of your joint may have some laxity or instability, or what other issues does your that joint have. You may be coming in for evaluation and someone has told you that you have knee arthritis, and that may certainly be the case, but there are often other things going on where maybe your ACL is lax or partially torn, or you've got patella tendinosis or quadriceps tendinosis. So interventional orthobiologics addresses all of those structures during your procedures. So when people have a joint procedure, it may involve numerous injections in that particular region. And some of these structures, like the support structures along the collateral ligaments of the joint, they span the course of the joint. So I don't just put one shot in that collateral ligament. I may put little bits of orthobiologics all the way along it. So it's a much more thorough treatment of the entire joint. And so I just want to include some pictures about what's involved. This shows on the left what's called a fluoroscopy device, or a C-arm, and that's using X-ray, real-time X-ray, to guide an injection into the patient's knee. And on the right, you can see there's an image. That's the fluoroscopy image showing an injection going into the joint space and also injecting into the bone of the patella itself. Treating below here, this MRI image shows swelling in the patella. That's called a bone marrow lesion. So not only do we inject the structures around the joint and the cartilage in the joint, we also treat the bones of the joint themselves in more advanced conditions. So many of you watching may have been told, oh, you need hip replacement surgery, or maybe you've got an issue with the side of your hip, over on the lateral aspect of your hip, and someone has said, oh, you've got trochanter bursitis. And they may have even put a shot in there and just kind of felt where it hurts and injected steroids in there. And on that note, whenever someone says, "Oh, you got trochanter bursitis, and let's just do a shot," I would say, "Well, show me," because back in the long time ago when I went through medical school, and even in residency, we were taught, oh, so if patients have pain right on the side of the hip, that's trochanter bursitis. Just inject right down to the bone and back off a little bit, and you'll hit it. Well, I look at hips under ultrasound day in and day out, and there are bursa in that region, but they are extremely thin, maybe the thickness of 1 or 2 needle thicknesses. And in reality, when patients are having just palpation-guided injections in that area, the person who's doing the injection is just really putting it right in your gluteal tendons, and that actually will damage the gluteal tendons. So if someone's going to come at you with a needle, I'd say I want to make sure that they're using guidance, because probably more than that, probably 19 out of 20 times when patients have pain on the side of the hip, and I look at it with ultrasound, there's no swollen bursa there. It's the gluteal tendons that are breaking down. And then if you go and just put a steroid injection right in those gluteal tendons, it might feel better for a little bit, but it actually damages the tendons even more. So a lot of patients that we see for hip problems are coming in because they've got hip arthritis, and they may even been told, oh, you're going to need a hip replacement. So one thing I definitely want you to ask when talking to someone about surgery, you want to ask them, are you sure that the hip joint is the source of the pain? pain in the hip and the groin area could be coming from your lumbar spine. It could be from the tendons in the area. It could be gluteal tendonitis off to the side. And then, do you have any allergies or sensitivities to metal? Because you're putting metal, when you do a hip replacement, they're cutting out the bone and they're putting in a metal replacement. So some people have allergic reactions to metal or hyperactive immune systems that can cause bad reactions to metal. Also, do you have diabetes or pre-diabetes? People having an artificial joint replacement are at higher risk for infection and higher risk for rejection of that joint if you have uncontrolled diabetes. And you want to know, have you tried different supplements to help with the pain? There are numerous supplements that are helpful for joint inflammation, including glucosamine and chondroitin, turmeric, omega-3 oils like fish oil, arnica, uh, and they can be very helpful. So you want to ask, is that worth doing a trial? And have you first been treated with less invasive advanced injection therapies like the orthobiologics that we're talking about? So looking at it just from the 3,000-foot view, we now can treat patients with severe arthritis to help avoid hip replacement. This doesn't work by regrowing you. Oh, I have a typo there. It's regrowing you a new hip. It works by improving the overall health of the joint. When we do injections, and what I'm thinking of it primarily is using bone marrow extract, which has stem cells and numerous other healing cells, we're improving the toxic environment in that joint. For years, we've thought of osteoarthritis as wear and tear breakdown of the cartilage, and there is a fair amount of that involved in osteoarthritis. But more recently, it's been found that it's more of a metabolic disorder of the joint itself. Our joints, our knees, our hips, the bones of the joints have stem cells in them, in the bone, and the stem cells work to help promote healing and to help keep the joint environment healthy and to decrease inflammation. As we age, those stem cell counts in the hip joint and bones and in the knee joint bones declines over time, and they decline much more rapidly than the stem cell counts that we find in the bone marrow in your pelvis, in your hips. And that's the back of your hips, called the iliac crest. That is where we extract bone marrow for treatments of arthritic joints. So we're treating the overall environment of the joint as well as trying to stimulate new cartilage growth or to at least halt the progression of cartilage breakdown. So we're also easily able to treat mild and moderate arthritis and treat the gluteal tendon degenerations that I talked about, or even different degrees of tears. And then people can get arthritis from prior surgeries by altering the gait of the way they move it. It can result in another joint wearing down. Or sometimes patients will have had a hip replacement surgery and they're still having hip pain. Well, we can't treat the hardware that's in there, but oftentimes the tendons and muscles and connective tissue around that artificial joint are what's causing the pain, and I can treat those. So those are the things we're looking at. So how do we help people avoid hip replacement? The Regenexx network of physicians, which is over 150 clinics, we all ask our patients to participate in the Regenexx patient outcome registry database. So what does that mean? Well, back in 2005, when they first started doing procedures, they had the foresight to say, let's track how much improvement our patients get with any of our procedures, whether we're doing a stem cell bone marrow procedure or platelet-rich plasma injections, which you get from the blood. Let's track how much improvement we get and how long does it last. And so what that means is whenever a patient in any of the Regenexx clinics has a procedure done, we ask you to fill out a survey, a function and pain level survey, to find out how much pain are you having now, what's your level of functionality, how much is this limiting your life, to get your baseline. Then, after the procedure is done, you get similar surveys emailed to you at 1 month, then 3 months, and then every 6 months, and every 6 months till 2 years. And then from there on, once a year for up to 20 years, as long as you are returning the surveys. And we do that for every joint from head to toe that we're treating. So as a result, we have the world's largest orthopedic outcomes database. And we use that to see what procedures and for what degree of arthritis or tendon tears is it effective. And so we track that. And so we're currently tracking 6,871 hip procedures, and the patients rate their hip improvement at 45% at 3 months, 51% at a year, and 63% at 6 years. That's their overall functional improvement. And I'm going too fast here. And I also notice I have another typo there. So when we look at it, so that block 2 there, that's how much improvement did they see. That's how much did they see improvement from their baseline. We also look at what's your overall functional rating. So 59% would rate, patients averaged a 59% functionality of their hip before the procedure on a scale of 0 to 100. By 3 months, that increased to 72% functionality, 75% at 1 year, and 76% at 6 years. There are numerous things that we track, but another one would be the pain. How much did your pain drop? And patients report a 37% decrease at 1 month, 43% at a year, and 61% at 6 years. So the key there is to note that these improvements persist. They keep improving. It's not like you get a bump of relief and then the pain comes back. Like with a steroid shot, you might get pain relief quickly, but be short-lived, maybe for a few months. With these treatments, it's more of a slower improvement, but a longer improvement. So I mentioned that trochanter bursitis condition. But really, almost 99% of the time, it's gluteal tendinopathy. What that means, pathy means bad or bad condition. So it's gluteal tendinopathy is chronic degradation and breakdown of your gluteal tendons. We have got several gluteal muscles that attach on the side of your hip, and they work to rotate your hip outwards. And it's similar to the rotator cuff muscles and tendons in the shoulder. So everyone calls it trochanter bursitis, but that really is erroneous. Rarely do I ever see a bursa, and when I do, that's swollen. And when I do see it, it's barely thicker than the needle that you would use to inject it. So on the right here, there's some diagrams of the gluteal muscles. On the left are the more superficial ones, the gluteus maximus, which actually does not attach right on that bump on the side of your hip. But the others are gluteus medius and minimus and the piriformis muscles, and some of the deeper muscles in your pelvis attach even further to the back. But tendinopathy is, I mentioned, chronic degeneration of the tendon fibers, which can progress to partial thickness or even up to full thickness tendon tears. And the key there is cortisone injections in that area. Cortisone will actually weaken the tendons and make you more likely to progress to higher grade tears. So the steroids that are used routinely throughout America and throughout the world, if people are doing injections, those corticosteroids are actually toxic to cartilage and toxic to tendon cells. So getting joint injections, getting a cortisone shot in the joint may help in the short term, but it actually accelerates the arthritis. And that's been well studied and known for decades. And there have been even more studies recently showing that even one joint injection can cause acceleration of your arthritis within a year. Everyone calls them cortisone injections. We really don't use cortisone in the clinics, but we use variations of it like methylprednisolone or Kenalog or the um, they may say we're doing a steroid injection or a corticosteroid injection, but in general, people call it cortisone because that's the first chemical steroid that was invented. So why will interventional orthobiologics replace selective surgery? Well, it's less invasive. We do enter the skin, but I use skinny needles, and in the most advanced and most invasive of our minimally invasive techniques, we use a thicker type needle called a bone trocar, but you never have to make an incision. So it's less invasive. You have quicker recovery. When after you have a procedure, you can get up and walk immediately. There's a little downtime because we expect you to have a brief flare as your cells are becoming active and starting the healing process. But even for our most invasive and potentially the more painful techniques, I'll give patients a prescription for pain medicine that for maybe 2 or 3 days. That's about all patients need. So you recover quicker, you preserve your biomechanics, meaning you keep your parts, you keep all of your parts. You're not losing the bones in your knee or the bones in your hip. That's all preserved. So when we're talking about orthobiologics, in Regenexx clinics, we're talking about two main categories. One is using platelets from your blood, and that's called platelet-rich plasma. I'll go over that in more detail in a minute. And the other is called BMAC, or bone marrow aspirate concentrate. So the bone marrow aspiration is the process of extracting it or sucking out the bone marrow with a syringe. And concentrate means we've taken the bone marrow out and we've separated out the blood. There's a lot of blood in bone marrow, and the plasma, and extracted the very, very potent layers of healing cells, which includes numerous cells, including stem cells that are more potent for healing than platelets. So those are the main treatments. And so many people say, well, if these cells are already in my body, why do you have to extract them and then inject them where you want? For instance, platelets are part of the blood, and MSCs, that's the term for stem cells. It means mesenchymal stem cells. They're present throughout the body. We have reservoirs of them in the bone marrow, but we have stem cells all over our body. They're in our tissues and in our organs, waiting to become active when you have injuries, or to help keep the healthy environment in a joint, for example. But so the platelets that we use, like for platelet-rich plasma, platelets become activated when they're exposed to connective tissue, like collagen. So a lot of people know, oh, platelets, those are the things that we don't want to form clots and cause a stroke. Like some people may have to take antiplatelet medicines if they've had a heart attack or a stroke, or people may think, oh yeah, I know platelets. Those are the things that form a scab when I get cut. So the platelets become activated and release many, many different growth factors when they come into contact with connective tissue. So when you get a cut, the platelets come in contact with the collagen in your skin, and they start the coagulation cascade, and ideally you stop bleeding real quickly. However, tendons and ligaments and cartilage, they don't have a good blood supply. And so it's hard for platelets to get to damaged connective tissue. So that's why we will draw your blood, we'll extract the platelets, and then we use precision guided techniques to inject them into the areas that are damaged. And interestingly, activated platelets also stimulate the stem cells in the area to become more active and to actually migrate towards the platelets. So platelets are are very potent modulators of healing. So when we talk about platelet treatments, I'm referring to platelet-rich plasma, or PRP. So that process means we draw your blood, we use concentrated platelets and inject those to heal areas of injury. So it's called platelet-rich plasma because imagine if we draw many vials of blood and we can separate out the layers of blood with a centrifuge to separate the red cells and the white cells from what's called the plasma layer. The plasma is a clear yellow protein-rich layer of blood, a portion of your blood where the platelets live. So now if we take the plasma from many vials of blood and we extract them and combine them into a large collection of plasma, we now have a large volume of plasma with platelets all intermingled through that plasma. We can now extract all the platelets from that and put them back in a small volume of plasma. So now we've significantly increased the concentration of the platelets in the plasma, and now we use that highly concentrated platelet-rich plasma to inject into the tissues. And we use that for mild arthritis or for tendon and ligament injuries. And the benefit with our Regenexx treatment is we have the ability to customize that dose, customize that concentration, and get a much higher dose than other clinics can do. And that's important because it's been well studied that the older we are, the higher number of platelets you need to be effective. And the more advanced the condition is, the more platelets you need. So those platelets, they release many different growth factors that other cells take up and start growing. And this diagram here shows a lot of the chemical names, the different growth factors that platelets will release. And there are growth factors that stimulate cartilage cell growth, bone growth, tendon growth, ligament growth, skin growth. There's growth factors that will stimulate more blood vessel growth into damaged tissue. But what's really interesting is there are growth factors that stimulate your stem cells in the area to become more active, and there's a growth factor transforming growth factor beta that will stimulate the stem cells, the MSCs in the area, to transform into their final cell type, like into cartilage or into bone. So stem cells, those are, the proper term is called MSCs. They're more potent. They do more, and they are more potent stimulators of healing. And we concentrate those, extract them from the bone marrow and concentrate them and inject them. And we also can get much higher concentrations of the healing cells through our process than most other physicians can get with simple bedside centrifuges that are used. So a lot of patients have heard, oh, I hear bone marrow biopsies are really painful. I know so-and-so who had cancer and they had a really painful bone marrow biopsy. And these slides here are to show what's involved. So in the middle there's that device in the purple gloved hand, that is called a bone trocar. And that is the device that we use to actually get into the bone marrow. That white part is, you can rotate it and pull it back, and a central sharp point can be extracted from it, and then there's a port to attach a syringe. Excuse me, like you can see in this picture, a syringe where we're drawing the bone marrow out. So when we do this procedure, it's very similar to this. It's a full sterile surgical prep. I'm in a surgical gown. We drape the patient. We take sterility very seriously. And it's very well tolerated. The patients hardly can tell what we're doing for a couple of reasons. One, we start an IV and you're awake but slightly sedated, and that helps tremendously. And two, we take only small amounts of bone marrow at a time. Excuse me, I have to get a drink of water. When you draw a whole lot at one time, it causes a big pressure change. A pressure change that your bone marrow cavity can detect, and that hurts. And that's what happens with bone marrow biopsies. when we do the bone marrow draw, I take little bits at a time from several different depths, from several different locations. It takes a little longer, but we do that because that's how you get the highest number of live cells. You get the most number of live stem cells when you draw little bits at a time. So it's a sterile procedure. We use sedation, and it's well tolerated. Um, And when we're drawing the bone marrow, there are many different cells, not just the MSCs, but there are other healing cells that are very helpful. This drawing shows the position that a patient would be in, basically lying on your belly. The zoomed in picture shows what the bone actually looks like. You have thick wall of bone, and then kind of a honeycomb structure is where the spongy bone where the bone marrow cavity is. And this shows the bone marrow trocar going into it. And then we aspirate little bits at a time from the backside of the pelvis. Um, this is an ultrasound image showing coming from the side. Going along here is the side of the iliac crest. This is the bone marrow trocar. This is how I guide the device down to the bone, and then I just manually kind of twist it back and forth and get into the bone. So the big thing I want to talk about is how our big advances in treating ability to treat severe hip arthritis. And that is using a technique called IO, short for intraosseous bone augmentation. So what that means is we take concentrated bone marrow extract and inject it directly into the bone. And we use that for moderately severe to severe arthritis. It actually, the recent study done by Philippe Hernigo shows even it's a very beneficial approach even for mild to moderate arthritis. The earlier you catch the arthritis, the higher your probability of avoiding total hip replacement is. We also do that. We'll do this treatment for people who have, let's say, they have mild hip arthritis, but for one of several reasons they get swelling or breakdown in the bone marrow itself. It's called a bone marrow lesion, and on an MRI image, that's what it looks like below here. Yet there's white swelling in the bone. Um, but to do bone augmentation, we do this in the office. We use a combination of ultrasound guidance and X-ray guidance, and use conscious sedation. But the big studies done by Dr. Hernigo um, were I'll go over it in a second. They were able to do these in the operating room and in the office. So they do this type of procedure in the operating room in cases where patients were having another surgery, or just in the office. But this diagram here shows kind of what's involved. There's different approaches of getting the bone trocar into the ball of the femur. You can come from this front approach or a little more angle, but the bottom line is you're trying to inject bone marrow concentrate into the ball to heal the joint from the inside out. Our cartilage grows from the bone marrow to the surface, and our stem cells that normally live in the bone marrow in this area, I mentioned earlier, get depleted over time. And what we're doing is recharging and repleting those stem cell counts in the bone marrow. So this is a study. I mentioned how the stem cell counts decrease in our joints much faster than in the iliac crest, and these are numbers on the knee. I haven't seen a similar scatter chart on the hip, but I know it's been studied. And I wanted to show this because a lot of people have said, well, yeah, that sounds good, but everyone tells me that if I'm too old for stem cells, my stem cells aren't good anymore. Well, that is not the case. The bottom here shows the age from 20 out to 100. The blue dots show the stem cell counts in the iliac crest, and this shows how they decline over time in the knees. So we take into account if elderly patients have a little low, they'll have a lower count than a 20-year-old, but they're still good counts. And so we use that as our worst case. That's where we choose how much bone marrow do we need to draw in order to treat someone who's elderly. So this shows why we do bone augmentation. So these are histology or slides showing cartilage on the surface. The subchondral bone is where you have chondral means cartilage, and then beneath that is the bone. So the stem cells live down in this area and promote growth of cartilage, and actually cartilage works its way up and grows from the inside out. And so when we inject, if you only inject it on the surface of the joint, those stem cells can get washed away. When you inject them right into the bone, they cling, they stay in there, and they work to help heal the environment. So I want to talk about the intraosseous bone augmentation versus conservative treatment study. Is a landmark study done by Philippe Hernigo. That he's the gentleman on the left in the suit, and I'm on the right at our last Interventional Orthobiologics Foundation annual conference. So he's an orthopedic surgeon in France, and he has done groundbreaking studies on treating knee arthritis and hip arthritis using bone marrow extract intraosseous bone augmentation. So this study we want to talk about, this is what really changed the game and allowing us to treat severe arthritis. So he did a study with 434 patients with hip arthritis of varying degrees. And they paired, in the study, they paired patients with mild arthritis and patients with moderate and severe arthritis. So they made a group of 217 who had regular standard care without surgery, and 217 that had the bone marrow aspirate concentrate injected into the femoral head. And we used 10 cc's of bone marrow concentrate injected. So he followed them for 15 years and looked at how many of the patients in the conservative care, the standard care group, had to have a total hip replacement, and what percent of the bone marrow injection patients ended up needing a hip replacement. And the hips treated with BMAC had significantly less progression to higher grade arthritis. So one, it slowed the progression of your arthritis, but you had a significant decrease in your risk of converting to needing a total hip replacement. So the treated hips on average had a 60% less chance of needing a total hip arthroplasty. That's THA, that's the hip replacement term. And the conversion was generally in those who did the bone marrow injection and had to have a hip replacement, it generally occurred later. And in the control group, it happened much, much sooner. So at 6 years, 14 out of the 217 BMAC group patients had to have a total hip replacement, but 66 out of the conservative care converted to a hip replacement. In that study, 44% of the patients had mild arthritis, 33 had moderate, and 17% had severe. And at 15 years, the BMAC group, the bone marrow group, had about an 84% 84% chance of not having a hip replacement, and the control group had the 60% chance of avoiding a hip replacement. So even the severe hip arthritis patients, there's a grading scale called the KL grading scale. So grade 4 is the most severe ones. Even the most severe arthritic patients, 76% of the treated patients avoided hip replacement at 10 years, and 65% were still avoided it at 15 years, and that's end stage hip arthritis. So that is a big change, and that is why Regenexx now, our recommendations are that even if you have severe hip arthritis, we still consider you a good candidate for our procedure if we do the intraosseous bone augmentation. So that's exciting because it's a lot of times people have been told there's no, you have only one choice. It's hip replacement, or we can keep doing injections just to control the pain, or take pain medicines. But there's definite hope. And so with any new procedure adaptation, there's different phases, and some the first phase, if you're new to something, you think, wow, this is amazing, this helps everybody. And that's kind of in the early ages of regenerative medicine, that's what people would think. And then as you become more mature, you think this is great, it helps almost everybody. And then more mature phases of adaptation, we say, let's figure out who's a good candidate. And that's what we do day in and day out at Regenexx. Every patient that comes in to my clinic, you have a thorough evaluation. It's not a 15-minute, or I mean, some patients who've gone to their orthopedic surgeon, it's a 5-minute visit. I spend about an hour to an hour and a half with you, doing a very thorough exam, an ultrasound exam of the part of your body that we're, in this case, your hip. And we spend a lot of time counseling about how can we make your chances for success better? What can we do with your diet to decrease your inflammatory state in your body? What can we do with supplementation? Such as adding supplements like omega-3 supplements, or fish oil, or turmeric, or resveratrol, which is the extract from grape skins. We look at what can you do from an exercise standpoint to increase your stem cell activity in your body. There are things that you can do from fasting can stimulate stem cell activity. So I spend a lot of time looking at all these different things that we can do to help your outcomes, and to really come down with a good candidacy rating. Everyone, at the end of our evaluation, I'll tell you, well, based on our outcomes data, and based on your exam, and based on your lifestyle, for instance, people who smoke don't heal as well. That decreases your candidacy. If you have uncontrolled diabetes, your healing environment isn't as good. So that might decrease your candidacy a little bit. If that's well controlled, uh, and if you're active, and we go through all these different parameters, we come up with what is your candidacy rating. So it's not a one size fits all treatment and or candidacy outcome expectation. So I encourage you, if you have been told no, all that's left is a total hip replacement, if you'd like to avoid surgery, there is hope. And in our clinic, we will let you know. We'll do a thorough evaluation and come up with a candidacy rating for you, and then move forward. So that at this point, I'm open for questions. If you have questions that you think of later, you can email us. You can contact the clinic at the phone number listed below, and we have our website at regenexxdesmoines.com. So I'll just keep that up there, and if you want to take that down, that's how you can get a hold of us. So let's see. So if you have any questions, you can either put questions into the chat area, or you can raise your hand. Or if you have no questions, that's also is fine. You can always reach out to us if you have questions, and for sure you can reach out to Natalie or Danielle in our scheduling team, because they have lots of information. They're not just the scheduling team, they're the patient education team as well.
A note from Mike on the webinar chat, Dr. Burgum.
Pardon me?
Oh, Mike put a comment in the webinar chat. Do you see
yes,
that?
Yeah, Mike Lang commented that I did stem cell on his knee in 2023 with great success. And hip was an issue then, but more of an issue now, and he'd like to set up an appointment. So that's great. Thanks, Mike. And yes, back then we may have said, well, keep an eye on your hip. Don't let it get too far. Um, or I may have said, boy, if it's advanced, we can't really do anything for you. But now, even with advanced arthritis, we can help you out.
Yep, and we'll have Danielle reach out, Mike, to you to get that scheduled. That's awesome.
All right. Well, if there are no questions, we'll leave it at that. And I thank you for your time. And hopefully this has been informative, and even more so, hopefully this has given those who maybe don't have a lot of hope about avoiding surgery. Now there's a lot more hope that we can help you avoid invasive surgery like total hip replacement. So again, feel free to reach out to us. I'll leave the contact information up here for a little bit, but otherwise have a great night. Thank you for coming.